Again, thank you for joining us today. My name is Erin Abner. As Terry said, I am a professor in the Department of Epidemiology and Environmental Health. I am primarily an epidemiologist. And so what does that mean? It means that I am someone who studies diseases in populations or groups of people rather than a clinician, right, who treats individual patients. And so what I was asked to talk to you all about today is forgetfulness, which is something totally normal that we all experience from time to time. But sometimes that forgetfulness can be concerning, and it can actually be a sign that there's something else going on. And so how do we navigate that? So I wanted to start by, I need to see if I can erase this line over here. That's going to bother me. Okay. Sorry about that. I want to start by talking a little bit about the progression of Alzheimer's disease. That's really what we're concerned about when we're talking about is forgetfulness, normal aging, or something else, right? And so when we think about Alzheimer's disease, we think about it as a continuum, not we wake up one day, the day before we were totally fine, and the next day we have profound problems with memory and thinking. That's not really how it works, right? This happens slowly over a long period of time. And in fact, what we know now is that what we call preclinical Alzheimer's disease, this sort of teal chevron over here on the left, happens probably 15 to 20 years before people have any type of cognitive symptoms, right? So just like a cancer, a tumor that you can have and not know about it because it doesn't cause any symptoms or anything like that, we can have pathology that causes Alzheimer's disease in our brains, but it doesn't actually cause us any problems. We're not going to experience any symptoms because of it. Now, for a lot of folks, they'll just move right along and they'll have that pathology and they'll carry that same amount of pathology to the end of life, and they won't ever have any problems. And that's fantastic. And we really want to know how those people are doing that. And there's a lot of research in that area, what we call cognitive resilience. How do we maximize our ability to resist the pathology of Alzheimer's disease? On the other hand, a lot of people progress, right? So we have this disease in our brain. What does that mean? For some folks, it means we start to have problems with memory and thinking. And the earliest indication that we usually see is something called mild cognitive impairment, in this case, due to Alzheimer's disease. And you can see it says there are very mild symptoms that may not interfere with everyday activities. And so we would expect, for example, someone with a diagnosis of MCI to be able to continue driving, to be able to continue working, to manage their home, to manage their own self-care, to manage their finances by and large. What we call functional activities are intact. They're able to take care of themselves, but they've noticed, or people close to them have noticed, that there have been important changes in their ability to remember and think about things. But again, without the interference in everyday activities, we don't have what we call dementia. So dementia, the distinction between dementia and mild cognitive impairment is that we do have that interference in our ability to care for ourselves and conduct our daily lives. So if we have mild dementia, right, and again, it's not a binary, we don't just wake up and have dementia and that's one thing. It's a very broad continuum and it looks different for everyone who has it essentially. But when we have dementia, that is interfering with our ability to care for ourselves. And we'll talk more about some of those signs later on. But for instance, we might not be able to make good financial decisions. We might not be able to file our taxes. We might not be able to follow a recipe. We might not be able to find our... Okay, now we're good to go. All right. So I explained a little bit about what Alzheimer's disease is and how it progresses. And now I want to talk a little bit about how common it is and sort of why we're all concerned about forgetfulness in the first place. And so the answer turns out to be that it's really, really common, right? And you probably knew that already. So the epi data tell us that something like almost 7 million Americans age 65 and older currently have Alzheimer type dementia. And that was from last year. The figure will be similar for 2024. And we note that about 3/4 of those people are age 75 or older. Age 75 is really where the incidence of Alzheimer's dementia really starts to take off. But that translates into about 1 in 9 people over the age of 65 having this. And this figure that we're looking at is from a report by the Alzheimer's Association. And it suggests that if if I'm female, which I am, right, that at the age of 45, which I'm just a little bit past now, my lifetime risk, right, so assuming that I survive for another 20 years, there's almost a 20% chance that I develop Alzheimer's disease. If I survive to age 65, again, there's another 20% chance that I'm going to develop Alzheimer's disease by the end of my lifetime. And so that's a fairly high risk, and that's a pretty shocking kind of disparity between men and women there. And again, it's not because women's brains aren't as good or we can't think as well. It's really a function of how much longer women tend to live versus men. So we do have a big problem and a reason to be concerned. So let's start talking about forgetfulness. What do we mean by that? So generally, if we're talking about forgetfulness, we're really talking about our short-term memory, right? So it's very normal to have problems remembering from time to time appointments that you may have, names and dates that you knew at one point in time. You may forget to do a household task. You may forget how to get to a place that you were once able to drive to. You may forget where you left things from time to time and not be able to find your keys or your car in a parking lot. Does that mean that you should be concerned that there's something wrong? Should you go to the doctor, for example? And so let's look at that. So we talked about forgetfulness, but what would normal aging look like? So we expect, even in the absence of any brain disease, if you died and we looked at your brain at autopsy, you have a very clean brain, we call it, no Alzheimer's disease, no cerebrovascular disease, no Lewy bodies, no TDP-43. Even then, as older people, we lose some of our cognitive ability, and I'll talk about why, but this is a example, right? So the y-axis, this vertical axis of this figure, is in what we call a z-score, which is basically units of how far something is away from a mean, like a mean where we expect it to be. So that 0 is the average, and 0.51 and 1.5 are higher than average, better than average, and the negatives are a little bit worse than average. But just in terms of neuropsychology, all of this that we're looking at is in a normal range. Plus or minus 1.5 standard deviations from the mean is normal. So these are normal declines, and we can see that essentially as soon as we're out of our early 20s, we start losing some of our spatial ability, we start losing some of our reasoning ability, some of our memory, and some of our processing speed. But again, it's not a crisis, it's not a problem, this is normal. And there's lots of reasons why this happens. And we can see, for example, another study suggesting that not all types of cognition actually worsen as we get older, or what we call our crystallized intelligence or our crystallized ability, like our vocabulary, for example, tend to get better as we age, and we tend to maintain those things. Whereas again, something like processing speed, we tend to decline in, even in the absence of any type of brain disease. So what is causing this age-related problem? A lot of this is what we call age-related synapse loss. So there are structural changes that occur in the brain as we age. Synapses, you may already know, connect neurons and allow them to communicate with each other and pass information back and forth. We start out our life with a whole lot of synapses, right? More than 1 trillion. And some researchers have suggested that if we lived to the age of 130 and we had absolutely no brain pathology, no brain disease at all, we still would have lost enough synapses by the time we turned 130 to make it so that we would express symptoms of dementia, even again, without having a brain disease. So losing those synapses is something that does cause changes in our cognition as we age. But there are lots of other reasons, right, that aren't Alzheimer's disease or other types of things that can cause us to have problems with our memory. Depression is a really big one, and one that's really common in midlife and older adulthood. Thyroid disorders, having B12 vitamin too low, Infections turn out to be really bad for our brains, and that can include urinary tract infections, influenza, COVID-19, all kinds of stuff. I'm sure you've heard about brain fog, right, related to COVID-19. That's an example of how an infection can cause forgetfulness. Head injuries, we know, are not good for our brains and can cause problems with our memory and thinking. Heavy alcohol use is really something that does affect our memory and thinking, especially as we age. Heart disease will do it too. Brain tumors obviously can cause some of those problems. And finally, Alzheimer's disease and related disorders. So how do we know, right, when it's forgetfulness, just normal aging, or it's a problem? So if you or someone you know has this issue where you notice that your memory and thinking is not as good as it used to be, or maybe you don't necessarily notice the change in yourself, but you notice that other people your age, your colleagues, your peers, seem to be better at memory and thinking, that there's a difference between you and them. We might notice that, and sometimes that might concern us. And so anytime that we're actually like really truly concerned with these changes or the difference between ourselves and other people, it's a good idea for us to speak to our doctor, in particular, our primary care physicians. And so what is a basis for a concern when we're thinking about forgetfulness? So as I've mentioned before, finding yourself lost in a place that should be familiar is a really telltale sign. And what I mean by that is if you are driving back and forth to a grocery store near your home, for example, and you get to the grocery, you do your shopping, and then on the way home, you look up and you find that you don't know where you are and you have no idea how to get home. That is concerning, and that is a cause to talk to your doctor. Repeating things is one that people sometimes worry about. And when we're thinking about repetition being concerning, we're really thinking about immediate repetition, right? Within seconds. Like I tell you a story, and as soon as I'm finished, I start telling you that same story again. Not, I told you this story last week, and now I don't remember that I've told it to you, and I'm going to tell it to you again. So that immediate repetition over and over of the same information or asking those same questions over and over, that's concerning. And that's something we would want to talk to a doctor about. Finding yourself all of a sudden not really remembering how your phone works, for example, your computer, those things are concerning. Your car would be concerning. And just forgetting to take care of yourself, right? Forgetting to bathe or brush our teeth. Forgetting basic hygiene can be a sign that something is wrong. Can also be a sign of depression and other things. So with all of these things, it doesn't mean that you have Alzheimer's disease, but it could mean that there is something going on that's causing your brain not to work as well as it could. It's just a simple graphic from the National Institute on Aging that sort of gives us, this is normal forgetfulness versus this may be a sign of a problem, right? And it really comes down to frequency and severity of the things, right? So let's say we make a bad decision, maybe we're on Facebook and we end up falling for some type of scam, right? That's not necessarily a sign that you have a problem, but making poor decisions a lot of the time, over and over again, that can be a sign that there is something going on that's a problem. Forgetting to pay a bill one time is not a big issue. Forgetting to take care of your bills every month, that can be a problem, right? Forgetting which day it is. Oh, I thought it was Wednesday all day today, but it turns out that it's Tuesday. Very normal. But losing track of the date or time of year, what we call being oriented to time. If we notice that we're no longer oriented to time, that is concerning. Sometimes we can't find the word that we want, especially if we're tired or we're not feeling well, for example. And so occasionally that's totally normal. But if we're having that problem over and over and we're having trouble having a conversation with people, that is concerning. And again, losing things from time to time, we all do it, totally normal, but constantly losing things and being unable to find them, and perhaps even accusing people that you live with of hiding those things or stealing them from you, that is a sign that we need to talk to the doctor. So I've been talking about memory mostly at this point, but memory is just one aspect of thinking, particularly short-term memory. So we may also notice that our ability to learn new things is changing, right? Maybe we want to learn how to play an instrument or learn a new game. We want to learn a language. We want to learn some new technology. We should be able to do those things. If we find that we used to be able to learn new things, but we're no longer able to, that can be a problem. A research participant that we had at Sanders Brown, one of the signs that caused them to sort of be aware that there was a problem was they were a magician and they started to be unable to learn new magic tricks. So learning new things is a sign that our brains are healthy. And when we can't learn new things, that's a sign that there could be a problem. We also use our brains to do math, right? Again, and make financial decisions. We have complex tasks that we have to plan and organize for. That's not memory or forgetfulness. Attention is another thing that's important. If you notice that you're unable to follow long passages when you're reading or pay attention all the way through a movie to the point where it's too frustrating to watch or engage in that type of media, that can be a problem. And again, being oriented to where we are physically and in time, and to recognize people. So there's lots and lots of aspects to our thinking. So sometimes even when our short-term memory isn't so bad, we might notice changes in math ability, for example, or judgment in our loved ones or ourselves that indicate that there could be a problem. So it's not just forgetfulness, not just memory. There can be changes in other aspects of our thinking that can tell us that something concerning might be happening. Okay, so far it's all been like, that's kind of bad news. What if I want to improve my memory and thinking, right? Can I do that? And so again, I think you can at any stage, right, in your cognition. Even people with mild cognitive impairment and dementia can improve their memory and thinking in different ways. So learning a new skill, if we can do that, that's good for our brains. Being social, spending time with our family and friends, going out, really taking care of your heart. A healthy heart is a healthy brain. I cannot stress that enough. And that is the best method of prevention that we know about. And I'll explain more about why. So if you have the capacity, daily walks, heart healthy foods, very good for your brain. If you have hypertension or diabetes, definitely do your best to manage those conditions. If you don't have them, do your best to avoid them. Sleep is super important for our brains, and we're really coming to understand this better now. But your sleep, right? If you're up all night the next day, it's hard to think, it's hard to concentrate. That translates over time into chronic deficits in memory and thinking. So getting enough sleep is super important. If we have sleep conditions like sleep apnea, getting those treated, super important. If we do have depression or depressive symptoms, talking to our doctor, getting that managed, that's important. And again, if we're drinking heavily, and it's not something that we can manage on our own, seeking help for excessive alcohol use will, in fact, improve your memory and thinking. So again, my mantra is good for your heart, good for your brain, bad for your heart, bad for your brain. And I'm going to give you a second. If you're particularly squeamish, you might want to close your eyes, but it's not graphic. It's just a model of the blood vessels in the brain. So here it comes. So that's, obviously the shape of a brain. That's a lot of blood vessels, and it's really important for the health of our brains for blood to be able to move all through there, right? And bring oxygen and nutrients to the cells in the brain. And obviously, when we have a stroke, that means that one of those vessels has gotten blocked and oxygen is no longer reaching our brain tissue. But on a smaller scale, if it's not blocked, it's just narrowed or it's not quite working as well as it should, that reduced blood flow in our brain is in fact a problem for our memory and thinking. So again, if we can maximize our heart health, especially in midlife, we're going to be much better off with our brain health in late life. And it's not too late to start. If you're already in late life and you want to get an exercise program going, talk to your doctor, take a walk. It's all good. What about supplements, right? There's all these nice bottles of things that we can do. What I will say is there is no evidence that there is any supplement on the market that actually is effective at improving your brain health, right? But this is a multi-billion-dollar industry. So people are very dedicated to convincing you that yes, you can take these pills and it's going to make your brain better. Just a non-exhaustive list of things that are not proven to be helpful in improving your memory and thinking. So really our best bet is exercise and heart health. Okay, so what if we do go to the doctor and we say we have a concern about our memory and thinking? So if you go to your primary care doctor, who you will likely go to, they will probably give you one or more short memory and thinking tests. If you have Medicare coverage at this point, you may have what's called an annual wellness visit. We can make the slides available, Chris. That's no problem. And they might order blood tests for us. They might do an MRI. They might order an MRI, so a picture of our brain. They might order some cardiovascular testing. And at the end of that, they might refer us to a behavioral neurologist. And here's one of my favorite ones. This is Dr. Greg Jica from the UK Department of Neurology and Sanders Brown Center on Aging. Okay, so let's say that we've gone to the doctor and potentially even a neurologist, and the doctor says I have mild cognitive impairment. So I talked about that a little bit earlier. So again, MCI just means that the doctor believes that there have been important or meaningful declines in your memory and or thinking ability. So it doesn't necessarily have to be memory. And yes, he is an awesome doctor, Greg Jica. I'm looking at the chat. But you do not have dementia, right? So MCI means you do not have dementia. And again, you should live your life without major changes. And the only other thing I really want you to know about MCI is based on our research, only about 50% of people who get a diagnosis of MCI will ever go on to develop dementia, even if they live quite a long time. So it's not a definitive move from MCI to worse cognition, right? So we get that MCI diagnosis, we get our chronic conditions managed, we take care of our sleep, we get brain stimulation through social engagement. We are likely to live with that diagnosis either for the rest of our lives or for quite a long time before having worse problems. And I want to show this image, which is a hypothetical depiction of the progression of Alzheimer type dementia. And so what we can see here on our vertical axis is these what we call markers moving from the normal measurement to the abnormal measurement. So as we move up in the image, we become more abnormal. And as we move across the horizontal axis on the bottom, our cognition progressively worsens when we get to MCI and dementia. Now you'll notice that there's this red line that's way out here, right? And it's the first thing that we see move into the very abnormal range, and that's called brain amyloid. This indication here, CSF PET, just means it could be measured in our spinal fluid, or it could be measured by a brain imaging technique called a PET scan. And both of those are fairly involved procedures. And I have a, let's see. Okay, perfect. And so this depicts what we call the amyloid hypothesis, or the amyloid cascade hypothesis, which basically says in the progression of Alzheimer's disease, the first thing that happens is abnormal amyloid accumulation begins. That leads to abnormal loss of synapses and synaptic dysfunction. That leads to a buildup of a protein called tau in the brain, which is very damaging to neurons. And then once we get that, we start to see atrophy in certain parts of the brain, particularly the hippocampus. And then we start to see changes in cognition. So all of these changes, right, are happening in the background. And we have no clinical symptoms until very far along in the process, right? But this amyloid, again, I'm pointing out, is the first thing that we think happens. And so I'm priming you for this. So if the doctor tells me that I have dementia, right, that's not good news. And it means that you have important declines in memory and thinking, and that those declines have made it impossible for you to carry out your daily life independently. So you may need help, right? Taking care of your home, doing your shopping, preparing meals, taking your medications correctly, taking care of finances, driving, for example. So there's a functional impairment there. And previously, up until last year, there were no treatments available that would, what we call, modify the disease. They wouldn't affect the pathology in the brain, but they would help us deal with some of the symptoms that those pathologies cause. And so medicines that you may have heard of or known someone who took, or maybe even taking yourself, are donepezil, these are the generic names, and memantine. And donepezil actually works very well to help people manage memory changes, declines in memory, but it doesn't change the underlying pathology or the underlying disease process. So it doesn't get rid of the Alzheimer's disease, but it helps you live with it, essentially. But last year, you may know, the US FDA gave what they call full approval to a therapy called Leqembi, which is the first disease-modifying therapy for Alzheimer's disease. Yes, my mom is also on Aricept, and it has helped her as well. So Pam McFarland's giving a testimony that yes, Aricept is a good drug. It has some side effects, and it's not for everyone. Some people won't be able to tolerate it. It can cause some stomach problems. It can cause some sleep issues in some people, but for most people, they tolerate it very well, and it's very helpful. And so now, in addition to these drugs that help us manage symptoms, we have this disease-modifying therapy called Leqembi. And just an image of their press release talking about this is the first and only approved treatment to reduce the rate of disease progression and to slow cognitive and functional decline in adults with Alzheimer's disease. And that the Centers for Medicare and Medicaid Services have approved Medicare coverage for Leqembi. Now, this is wonderful news, but it's not the end of the road for us. This is just the beginning. So there's a lot of concerns about Leqembi, but what Leqembi does is it acts on that amyloid, that first red line that I showed in that figure, and it binds to the beta amyloid that's in the brain. And once it has bound to it, it breaks up the plaques and the other conglomerations of amyloid in the brain, and then those are cleaned out of the brain in cerebrospinal fluid. And I will also say that that is what usually happens with brain amyloid. It's always there in adults, but it gets broken down and cleaned out. So, and especially during sleep, which is why sleep is so important. So Leqembi attaches to amyloid and removes it from the brain. And so again, the idea is if we get that amyloid, we can prevent further downstream damage from these other things if the amyloid cascade hypothesis is well supported, which we don't necessarily know 100%, but we hope, and there's a lot of encouraging evidence. So let's look at a little bit of data from the trial. What was the basis for the approval of Leqembi? Here it's called lecanemab. That would be the generic name. And so what we're looking at is a figure that shows the difference in the amount of brain amyloid for people who were randomly assigned to placebo, which is that black line at the top that's sort of horizontal, and the green line, which is the people who were assigned to Leqembi or lecanemab. And we can see that basically right away, after 3 months of being on the drug, that the people who were taking Leqembi had much less brain amyloid than the people who did not, although they both started out with the same amount, right? They start out in the same place at this 0 here. And so very convincing evidence in this figure that Leqembi does what it claims, and it will remove amyloid from the brain. And this process continued to be more and more different, right? More and more amyloid removed, all the way to 18 months. And the figure ends at 18 months because the trial ended at 18 months. So we don't actually know what happens after that, and that is part of the controversy. But the people in this study definitely had their brain amyloid reduced if they took lecanemab. What about things that we care more about, right? So, okay, you can remove my brain amyloid. That's fantastic. Does it actually help me as a patient in any way? And it seems like it does. So this figure is called a forest plot. This vertical line, the dotted line, is 0. So that means there's no difference. And then these negatives might seem like something is worse, but it indicates it favors lecanemab. And so basically this is a measure, the CDR-SB is the clinical dementia rating sum of boxes. It's an overall measure of our cognitive health. It covers all of those domains that I mentioned earlier: memory, attention, judgment, problem solving, community affairs, home and hobbies. So it's an overall assessment of all of our memory and thinking. And it says, for people who took lecanemab versus the people who took placebo, their CDR score got worse more slowly than the people who took placebo. So both of them continue to decline over that 18 months, but the people who took lecanemab declined more slowly. This is what we call a subgroup analysis. And what we can see at the top, where it says overall, is the primary effect of the study medication. So that resolves to about a 0.5 point of difference on the CDR sum of boxes. And it says it's a 27% decline. And that's sort of hard for us to wrap our minds around what that means. But in terms of time, in that 18-month trial, it means that the people who took lecanemab on average would take 6 months longer to decline to the same place that the people who took the placebo would decline to. And the estimates for different groups of people are a little bit different. And there's some evidence that people who have 2 copies of what we call the ApoE4 allele. Yes, I will, Reggie, I will answer your question at the end. The people who have 2 copies of the ApoE4, which is a strong genetic risk marker for Alzheimer's disease, may not respond as well to this medication as everyone else. And in fact, the VA hospital systems, for example, will not provide the medication to people who have a 4-4 for their genotype for ApoE. So it is a concern. But for everyone else, we see an indication that taking this medication slows the progression of this disease, which is good news. So again, if we were to take Leqembi, it will not lead to an improvement in our symptoms. That's what Aricept or donepezil, Namenda is for. So we can take them together. That's important for you to know. It may slow the progression of dementia by about 6 months within this 18-month study period that we know about. And again, we don't know what happens after that. It is burdensome in terms of cost and time, right? So they have set the cost of Leqembi at $26,500 a year. Medicare will pay for about 80% of that, if I understand correctly. But that's still a substantial amount of out-of-pocket cost for people. And in addition to that cost, Leqembi has to be taken at specialty infusion centers, which are typically at academic medical centers like the University of Kentucky. We do have a Leqembi clinic here that Dr. Jaika runs. So it's not widely available, right? If I'm living in Eastern Kentucky, for example, am I going to drive to the University of Kentucky every 2 weeks for the rest of my life to get this infusion? I don't know. So it's quite burdensome at this point. It's pretty safe for most people, but again, this genotype problem is there. There's a particular medical condition called cerebral amyloid angiopathy that can be dangerous with Leqembi. And people who take blood thinners should not take Leqembi either. And why is this? Well, so again, we all agree and we can see that Leqembi removes amyloid from the brain, but this 6-month slowing or this half a point on the CDR sum of boxes, there's a lot of people in my field who say that's just not a big enough benefit for everything that you're asking patients to take on in order to have this medication, right? So the patient burden and the potential side effects. And what are the side effects that we're concerned about? So there's this thing that we call ARIA, which stands for amyloid-related imaging abnormality. And then there's two versions, an E and an H. And E stands for edema and H stands for hemorrhage. And so of the two of those, the hemorrhagic version is much more dangerous, but it's also less common. But you have a fair number of people who are going to have this problem. And so what is this problem? It causes, Leqembi attaches to amyloid, right? Those plaques that we don't want, but it also attaches to amyloid that happens to be in our blood vessel walls, especially if we have cerebral amyloid angiopathy, and it can cause bleeding and swelling in the brain. So in addition to taking, this infusion every 2 weeks, you also have to have regular monitoring from an MRI to make sure that you aren't having this dangerous condition happen. If people do have ARIA, what they do is discontinue the medication and then restart at a lower dose once that condition has resolved. Let me take a quick look at the chat for questions. Yes, Chris, it's a lot. It's very expensive. Okay, yes. All right. Okay, so my last slide. Mild declines in memory and thinking function are part of normal aging. 100%, we will all experience it. Distinguishing between normal aging and a problem mainly depends on the severity and frequency of the memory and thinking problems, right? Again, not I lost something or I forgot where I parked my car, but I'm doing this all the time. I'm getting lost while driving. I'm repeating myself constantly. I don't know things that I should know or that I used to know. Those are reasons to go see the doctor. And now, for the first time, we have a disease-modifying treatment for Alzheimer's disease. We hope it will be the first of many. There's another one called donanemab that we expect to be approved by the FDA anytime now. Probably will not be different in terms of cost, but this one is a single infusion per month versus 2 per month indefinitely. And donanemab in the trials, they actually discontinued patients from taking it when they had reduced their amyloid to the level that they wanted. And so donanemab is not designed to be a medication that you take indefinitely. You take it until your brain amyloid has decreased. Okay. So let me go back to Reggie Goffinet. I hope I'm saying your name right's question. Is there a definitive connection between amyloid plaque and Alzheimer? I read autopsy results sometimes show brain changes in people who had no symptoms. This is a fantastic question, and it's a complicated question. And it all depends on what you mean by Alzheimer's disease, right? So the pathological thing that we see in the brain, the definition of Alzheimer's disease pathology is amyloid and tau. And so there is a definitive connection between amyloid and what we call Alzheimer's disease. It is Alzheimer's disease. But there is not a definitive connection between amyloid and cognitive problems, MCI, dementia. And this is absolutely true, what Reggie says. Autopsy results can show brain changes in people who had no symptoms. And this goes back to what I said about people who develop MCI, for example, but don't go on to develop dementia and this preclinical AD idea. So we can absolutely, and we have had many of them be participants at Sanders Brown, people who have very good memory and thinking all the way to the end of their life. And we look at their brains at autopsy and we see evidence of Alzheimer's disease. They have plaques and tangles. What they don't have ever is very severe Alzheimer's disease. So when we see severe amounts, severe burden of Alzheimer pathology, which really involves tau, so amyloid by itself, not going to cause cognitive problems, amyloid plus tau, now we have problems. it is the disease, right? So Alzheimer's disease, neuropathologic change involves amyloid and tau. Alzheimer's disease, dementia can happen, but won't always happen when we have amyloid and tau. So again, there's a lot of research now going into what are the factors that help people just have this stuff in our brains, but not actually have memory and thinking problems. That would be really helpful to know. Linda Asher is asking, do studies show if dementia is hereditary? So family history of dementia and genetic risk for dementia are not exactly the same, but both of them are associated with increased risks for dementia. So for example, my dad's family, both of his parents had Alzheimer's disease and died with Alzheimer's disease. But my dad and all of his siblings at this point, and they're all in their or approaching their 70s, or they're in their 70s, none of them have memory and thinking problems at this stage, while both of their parents had them at that same age. And so it may be, right, that my dad and his siblings never developed thinking problems. They never developed dementia, no matter how long they live. But it may just be that the differences in their lives growing up versus their parents. So my grandmother, for example, had an 8th grade education, whereas my dad and all of his siblings graduated from college and worked in professional jobs, while my grandmother was a cook at a school. The healthcare that was available to my dad and his siblings, especially with regard to heart disease, is much better than what was available to my grandparents. And so I wouldn't be afraid necessarily that because my grandparents had Alzheimer's disease, for example, that I'm also going to have it. It's not that deterministic. There's a lot that goes into it, a lot that protects us, especially education, especially, again, heart health will protect our brain. So there is a link. There is some genetic risk, but most people who have Alzheimer's disease don't have like a single genetic factor that explains why they have it. And a lot of people who have parents with Alzheimer's disease never develop it themselves. So it can be concerning, but it's not something to be overly worried about. Pam McFarland mentions about Leqembi. This is cost prohibitive for most people who could actually use it. I do not disagree with you at all, and that is part of the controversy, right? Like, wonderful, you've made this medication, but in order for it to actually move the needle, particularly in a public health sense at the population level, keeping people living independently, keeping them out of nursing facilities, we're a long way from having this drug fulfill that goal for us. It may help individual patients. It's not going to be very helpful on the population level at this point. Satya asks, do we recommend a genetic screen for those with MCI or memory problems? Well, I do not recommend necessarily that people who are concerned have a genetic screen. You may have a genetic screen as part of a workup or diagnostic workup if you go to a physician, but I would never recommend that you obtain one on your own. It's just not informative enough for you as a person, as an individual, to know what will happen. And so usually what will happen is people get information that they might have an E4 allele or even 2 and be very worried, but that's not helpful. And it may not even be accurate. So always with a genetic counselor or a doctor, I would do that, but not on my own.